We are talking menopause, perimenopause, hormone replacement therapy, and very specifically vaginal health during this whole thing, which I don't know about some of you ladies my age or a little younger who haven't hit perimenopause yet, but this whole topic is like a little scary. I was like, oh my gosh, what are you saying is gonna happen to me? But the really cool news is that there's good news. There's a lot we can do about it and prevent and even restore the health there. So my guest today is going to fill you in on this. She has 30 years of experience. Her name is Dr. Maria Sophocles. She's a gynecologist and public advocate for women's health. Her mission to close the gendered healthcare gap inspired her viral TED Talk and the creation of legislation providing access to contraception in New Jersey. Her Princeton, New Jersey clinic and virtual practice serves 30,000 women in the US and globally. And she's currently working on a documentary about sex and menopause and developing a health clinic in rural Kenya. She's married. She has 4 grown children. She's awesome. Great personality. You guys are going to really enjoy this episode, I think. Check out her website for access to anything I just talked about. It's Maria Sophocles, and that's SOPHOCLESMD, mariasophoklesmd.com. And please go give her a follow on Instagram because she's amazing and super informative. And yeah, let's kind of help boost and getting her word out. Let's put a bigger mic on her, you know? So it's Maria Sophocles MD is her Instagram handle. And she has a book available for pre-order on Amazon. It's called The Bedroom Gap. We're going to have her back on when that comes out and get a little more deep into that book on another episode. But yeah, get ready to just get informed like crazy, ladies and men too. Like if you're awesome, maybe listen to this so you can like know what's going on in half of the human population. All right, let's go ahead and get into it. Here is Dr. Maria Sophocles. This episode is brought to you by Peluva. So Peluva, Peluva, those are Mark Sisson's new zero drop minimalist shoe with that distinctive 5-toe design. I have been loving them. I've been a longtime fan of barefoot shoes, and I was very resistant to the little 5-toe articulation personally at first because, just being real, I thought they looked really nerdy, and I was like, oh man, yeah, I love Mark so much, and I get what he's doing, but I'm not wearing those nerdy shoes. And then Brad Kearns, who's also involved with that project, was like, no, Tara, you got to try them. Tara, you got to try them. Tara, just come on, try them. And I tried them, and I kid you not, I enjoy them so much that I actually like how they look now. Weirdly, I can tell. So like the purpose of that 5-toe articulation is so that your toes can move more dynamically. So with other barefoot shoes, like I've been a long time fan of Vivos, and I'm still a big fan of Vivos, but they have just that big toe box, right? Which is awesome. So I didn't really feel like the 5-toe articulation was necessary, to be honest. But as I've worn them, I have experienced how awesome that is. It was actually been quite surprising for me. And I wore them this morning. I wear them all the time, and I'm really, really enjoying that freedom of movement on my toes. So yeah, Brad and I have been going back and forth. I'm like, dude, I actually love them. And he offered to sponsor the podcast with Peluva and also offer you guys a 15% off code, which I was like, okay, cool. Yeah, I will gladly introduce my people to Peluva shoes. So you can use code Coach Tara at peluva.com, or you can just go to peluva, peluva.com/Coach Tara, and you can get that 15% off discount. Make sure you snag some of the socks while you're there because you're going to need the toe socks. Okay. All right, let's get into the episode. Okay, so Dr. Sophocles, I'm so pumped to talk about menopause and hormones and hormone replacement therapy and what happens to our vaginas and all of these things that have not been talked about enough at all. I remember being a teenager and knowing what erectile dysfunction was as a freaking teenage girl and Viagra and all of this, but I didn't know anything about what's going to happen to my own vagina when I go through menopause. And thank God we have so many Gen X women out there that have just taken this by the freaking horns and are just changing the entire menopause game. And so I'm so excited for you to help educate my people. Thank you for coming on and talking about this very important issue for women. We need help. So I
Tara,
think,
it is so good to be here. I love talking about this stuff. I was on stage last night and literally it was like, I think they had to pull me off the stage. It was a little embarrassing. I was like, wait, I got more,
hmm
because it's so exciting to see what a difference you can make that just
yeah.
education makes. And we're totally in the desert of education. And thank goodness this is coming out of the closet, so to speak. One thing I talk about a lot is the lack of attention women's health has gotten in medical education. So by the way, it's not just you and your friends and that your moms didn't tell you. It's not even just that sex ed didn't teach you this, which is a whole other beef we can unpack, right? We need to morph sex ed. Sex ed should not be like, remember, was it Mean Girls or something where they're like, just don't have sex ever. That's what
Right.
sex ed is, right?
Right.
That's the dumbest sex ed ever because
Totally.
no teenagers go, okay, I'll have sex never.
Okay. Yeah.
And we should be teaching, I do think we should revamp sex ed in this country. I think
hmm
we should be teaching it as pleasure focused, not
Yeah.
fear based. Like
Yeah.
you're going to have sex, so do it intelligently, learn about
hmm
contraception, do it with consent. Hello,
hmm
consent, it's a real thing.
hmm
And understand what's going to happen over the next 50 years from age
Right.
15 to 65 or 15 to 95. How's
Right.
your body going to change? How's your partner's body going to change? Change is okay. We don't all have to stay
hmm
Hollywood perfect. Um, but also to learn about pleasure. How do you get
Yeah.
pleasure? How does your
Yeah.
partner get pleasure? Let's make it a two-way street. None
Totally.
of this is in sex ed today.
Totally. Totally.
Um, Actually, 3 states out of 50 do this, but that means
Mm.
47 states don't. So
Mm.
we got a long way to go on that.
Yeah.
But really, that's how we can change the next generation. That's how you and I
hmm
can make sure the 15, 16-year-olds learn about sex correctly. So
Yeah.
they do it with pleasure, so they do it safely.
Mhm.
In Holland, where they teach sex ed from like age 4 on, those
Wow.
guys have among the lowest unplanned pregnancy rates. They
Wow.
just don't get pregnant unnecessarily because they wait, they have sex when they're ready. They have sex
hmm
based on pleasure. They use contraception. Like we just need to polish that up a bit.
Yeah.
But we
Definitely.
also need to fix medical schools, Tara. We 92% of doctors do not have training in menopause. So they don't know about something that affects 100% of women. 100%.
Wow.
That's kind of that's like ageism and sexism intersecting.
Yeah. a
And
hundred
it's
percent.
right in medicine. Crazy, right? So
Mm-hmm.
one of my missions is to really disrupt the medical education system and say every single med student has to learn about menopause, and then doctors in every single specialty have to learn about menopause. Because if you're an orthopedic surgeon and you have women coming in with a broken
True.
hip, guess what? It's because they didn't get estrogen. If you're
Yeah.
an ophthalmologist and women at 55 get different changes in their eyes more than 45, it's because of estrogen. Dentist,
Yeah.
estrogen. Hair
Mm.
loss, estrogen. So we got to
Right.
change so everybody gets that. But why don't we start with what actually happens so we get sort
Yes.
of to the fun sex part. What
Yeah.
happens in menopause physically, biologically to our bodies? Well, what happens to I'm going to focus on the genitourinary system, right?
Yeah.
And because we could talk for hours about what happens to the bone and the heart and all that stuff's really
Yeah.
important. But what you might not know, and what your listeners might not know, is a lot of the menopause symptoms, like hot flashes, actually are time limited and then they go away. Thank God.
Mm-hmm.
But the changes in the bladder, the vulva, the vagina, the clitoris, those things don't get better. They get worse and they're chronic and progressive. That's kind of bad news. That
Mm-hmm.
means you're not going to outgrow it. It means you're going to wake up and be 58 or 63 and go, why do I not want sex anymore? Why does it hurt to have sex? Why can't I have an orgasm like I used to? And you'll feel broken and you'll feel
Mm-hmm.
alone and ashamed and you'll be embarrassed to talk to your partner about it. And the reason I'm being Debbie Downer is these are the patients that come see me all
Yeah.
day, every day. And so after 30 years of listening to that, I was like, oh my God, I gotta do something about this. So that's why I did a TED Talk so that the learning could take place globally. So that TED Talk
Mm-hmm.
has like over 1 million views. And so that's good. People are looking at that.
Mm-hmm.
And then I realized I better write a book so we can more fully look at what's happening to sex in midlife and not just what happens biologically, but what are the what are the forces that make us feel ashamed as women if we don't stay sexually
Hmm.
perfect? So history, right? Because history's always been told us sex is for men. And culture, our cultures that are like, men have needs, you must serve the man. He
Right.
has sexual needs. And I mean, gosh, I kind of call bullshit on that. Like, I think it's time that we change the narrative and say, hello, hello, women have needs. One is, I'd like my body to stay healthy, and you're a master of that. Two is, I'd like to be better at communicating my desires for what I like sexually to my partner, right?
Hmm.
And three is, I'd love socially for it not to be taboo for women to talk about sex or masturbation. Men
Right.
are taught that they can masturbate from the age of 0 to 90, and that's normal. We just expect that, and that's actually totally fine. But women, it's like this shameful, dirty secret. Like, what? Where did that double standard even come from? Because we know, and statistics show that women who masturbate actually know their bodies better, know what makes them sexually happy better,
Yep.
and
Yep.
communicates that to their partners better.
Exactly. Hmm.
So just the topic of masturbation is something that we got to get out of the
Yep.
closet. Let
Totally.
I'm digressing a little. Let's go back to the bladder and vagina. When we lose estrogen, okay, that's what menopause is. The little ovaries stop making estrogen and progesterone and testosterone. When they do that, the bladder suffers, the vagina suffers. What happens in the vagina? If you go to my TED Talk, there's this great little 14-second animation. It's awesome. You can see exactly what happens when you take estrogen away.
Mm.
The thickness of the tissue goes away, the blood vessels go away, the collagen breaks down and gets replaced by kind of crappier quality collagen. So things get stiff and painful, and you can't get wet, bottom line. That
Hmm.
sucks. That really does.
Yeah.
So that's what happens physically. Is it fixable is what I
Yeah.
think you know. And the answer is totally. It's fixable with over the counter things, and it's improvable with over the counter things. It's fixable with vaginal estrogen. Okay. If we give the vagina vaginal estrogen, it is like pouring plant food on a plant. The blood vessels come back, the collagen restores, and we get moisture again, and we get comfort again. So
Even
that's
if it's already been going that direction, it gets restored.
95, it'll work. If
Okay,
you're
cool.
55, it'll work. Now, if you're 45 and your vagina's gone from an A to a B plus, I mean, you're not going to notice that much change, right?
Uh-huh.
You're 75 or 80, it's literally like someone
Cool.
in the desert and someone brought you to a beautiful lake, you know.
Okay. Okay,
So
cool.
so
And quick
again,
question on this, because
yeah,
I'm 43, just turned 43 last weekend, haven't
yeah.
started menopause at all, still have regular cycles. And I bet a lot of women my age are wondering this. I'm like, how early can I start that so this doesn't happen to me?
Yeah. So the answer is there's no such thing as too early, and there's no such thing as too late. Vaginal estrogen is so crazy safe. It's been when we put
Cool.
all the studies together, we have like 1 million women worth of studies. The risk of cancer from vaginal estrogen was basically zero.
Yeah.
So probably safer than Tylenol, and doesn't cause autism. So, it's crazy safe. It probably should be over the counter, in my opinion, but that's my own opinion. So, no, you're not too early to start. But remember, the earlier you are, the more you already are at an A. And so there's going to be
Yeah.
little that you'll notice. So don't be upset if you get on
Mhm.
at 43 and you're like, it's a little better. Well, it's a little
Mhm.
better because you're already really good at making moisture. You already have all that.
Yeah.
But the flip side is if you start early, then you're never going to have that dip. You're never going to
Yeah.
go, I'm in the desert. It's so dry. It's hard.
Yeah, no, horrible.
Yeah. So I'm a big fan of it. I'm not
Mhm.
shy about that. The cool thing is it's not really a systemic thing. It just works where it's supposed to. So bad news, it's not going to keep your brain function better. It's not going to prevent heart disease. It's not going to do all the systemic things. Sorry. Good news is it does what it's supposed to do really, really well. And it comes
Mhm.
as creams or little tablets or a ring. It's half a dozen companies. There's five actually that make it. So not hard to get, and it's cheap. I mean, the creams are the cheapest. You can go to Mark Cuban's website or whatever. It's like $13 or something. So
Mm.
if your insurance doesn't cover it and it's crazy expensive, go find,
Mhm.
the HRTclub.com or Mark Cuban
Mhm.
somewhere where it's cheap, because it's really cheap to make. So you can,
Okay.
okay. Now
Okay, so
the over-the-counter stuff, just real quick, Tara, does not make new blood vessels, does not make new
okay.
collagen. So it's not going to restore anything. So if you're 58 and it's already painful, these are not going to correct, but they're wonderful band-aids. They have hyaluronic acid in them. They're little suppositories. Many companies make them, like Mia Vita is the name of a product from a company called Fem Pharma, or Bonafide is a company that makes Reverie. Hyalogyne is another one. There's several on the market. They
Okay.
all have hyaluronic acid, which we use in cosmetics.
Mhm.
They all make it feel moist. So that's good. But remember, they're not making new cells. They're just band-aids, they're not fixing.
Mhm.
Okay. So
Okay.
that's how we can help the, oh shoot, the vagina's getting dry stuff. The bladder is only going to get helped with vaginal estrogen. The bladder, as we age, that's why women get urinary tract infections. To help the bladder, you need the estrogen in the vagina, because the opening to the bladder is in the vagina. So to make that healthier, you got to get the vagina healthy. That's really confusing for doctors and patients alike. Like, why do I fix and make the vagina healthier to save my bladder? That's why. Sorry if I confused you.
No,
But
that makes
yeah.
complete and total sense. Yeah, because I think that some women on HRT might not do the vaginal one just because they're like, oh, I'm just trying to optimize my hormone levels. And then they're getting chronic UTIs and they may not have ever heard that before. So thank you.
I want you to think of systemic HRT
Mhm.
as wonderful for everywhere, but think of it as it has to dilute throughout the body, right? So it can only help the hair this much and the skin this much and the heart this much. And by the time it gets to the bladder and the vagina, there's just not that much there. They're teeny
Right.
little doses. So it's just, quite frankly, often not enough. Patients say to me, "Oh, I can't do both, I'll overdose." Well, that's in their mind. The fact that if you'd use two things, you overdose. No, you don't. If you have a severe, terrible headache or sore ankle and you take one Tylenol and one Advil, you're not overdosing, you're just helping the problem, right? And same thing.
Mhm.
The vaginal
Mhm.
estrogen isn't going anywhere, so you're not overdosing on anything. So don't ever let yourself think that you're optimizing hormone levels or you're overdosing. That's not correct at all. In fact, when we give vaginal estrogen, we cannot detect it in the bloodstream. So your blood test shouldn't be changed at all from that.
Okay. What kind of problems are you seeing in the HRT world right now that women should be aware of? And could you talk a little bit about recommended paths for getting on HRT? Because some women still like they just do not have good
Yeah.
information and they're having a hard time finding the right person. Could you help educate them on that path?
Totally. Finding the right person is very hard. There are not many properly menopause trained clinicians in the US. This is changing. So literally every year there's more. I have trained many, many in many different states, but believe me, if I've trained two people in Iowa, that leaves a lot of Iowa untrained. And if I've trained
Mhm.
three people in Oregon, that's still really hard. So you can
Mhm.
go to menopause.org, and that's the Menopause Society, and put your zip code in, and that's helpful. All that really means is it's someone who took their course and read the little booklet. So it doesn't
Okay.
mean they have, like, I have 30 years of expertise. So you're not going to get that, but you can at least get someone who's better than someone who's had nothing, right?
Mm.
What I'm seeing, unfortunately, because this affects mostly women sort of 40 to 70, women have more purchasing power than they used to. So there's money to spend. And when there's
Mhm.
money to spend, opportunistic people and companies come
Yep.
up. And the louder they are on TikTok and Instagram, the more patients think, I guess that's the right way. Be very
Mhm.
careful. I'm going to give you an example. The word bioidentical. Most people don't know what it means, but it sounds safer and they more natural. They always say bioidentical is better, it's safer, more natural. Bioidentical just means biologically identical to what your ovaries made. And that's great. There's nothing wrong with using that. Bioidentical estrogen and progesterone are made by big pharma companies. So you don't have to go to somebody's special hormone clinic or hormone balancing anything to get bioidentical hormones. Bioidentical hormones are available by prescription, and you can pick them up at Walgreens or Rite Aid or CVS or Amazon or anywhere you get regular, anywhere you would pick up amoxicillin or penicillin, you can get bioidentical hormones. They are not specific to fancy hormone specialists or clinic. I think that's really important that people know that.
Mm.
Okay, so if I write you, Tara, let's pretend you're 53 now, and you come to me and you say, I'm in menopause, I'm having no periods, and I can't remember anything. I'm having a brain fog, and my shoulder hurts, and I'm
Mm.
grouchy. And I say, let's give you estrogen and progesterone. You do not need that custom made up. And you don't need a lot of blood work. You don't need 100 levels of estrogen. There's no, we're not like balancing or optimizing. A lot of these words have come into lingo. Estrogen dominance. These are things
Mm-hmm.
doctors did not create. Science did not say that. These are things that have come into layperson opportunities. This is important,
Mm.
really important. Okay. Um, so when you talk about optimizing levels, remember for a 43-year-old, your levels are fluctuating all
Mm-hmm.
cycle long. And when you become perimenopausal, meaning
Mm-hmm.
the decade when they're just not functioning, there's a little bit of a roller coaster to all these
Mm-hmm.
numbers. The last thing you want to do is draw your blood because the numbers are all over.
Hmm.
You never want to follow the numbers. You want to treat symptoms. So any good perimenopause expert does not, it doesn't mean you never need blood work, by the way, and it doesn't mean it's wrong to do blood work, but you don't necessarily base dosages and pellets and creams on those numbers because in perimenopause, they're all over the map.
Mm-hmm.
In menopause, they're all super low. So you can use very standardized uh, FDA approved estrogen and testosterone and progesterone. And the estrogen and progesterone are all FDA approved and they're available by prescription and pick them up at CVS or Walgreens. Testosterone is a different beast. There is no FDA approved testosterone in America yet. I think we're going to get it. Okay. I think we're 5 to 10 years away, maybe less. And it's coming, I promise. But right now, if you want testosterone, that's when you need blood work because we want a baseline and we want to check you 6 weeks after you start it. And the testosterone must be compounded. I must call a compounding pharmacy and say, give Tara this 1 or 2% testosterone cream, at this level. Then I'm going to check your blood work and then adjust. So that is where
Okay.
you follow blood work and you keep it in a safe range. It's really easy to keep it in a safe range as long as you're not using pellets. I'm not saying nobody should use pellets. I'm saying pellets are very high dose. So you never want to
Mm-hmm.
start with pellets. You can sort of work your way there. If let's say I was giving you the compounded stuff and even on kind of the top normal doses of that, you were like, I'm sorry, I'm just not feeling it, not feeling the love. We could try an injection monthly or we could try pellets, but those are you're playing a little more with fire because they're very high
Mm-hmm.
doses, much more likely to get acne, chin hair, stuff you don't want.
Mm-hmm.
So testosterone, there's a tightrope that we walk with
Mm.
too much and bad side effects, not enough, don't feel the love. So with testosterone, you want to make sure you're with someone who really knows what they're doing. You want to hear something crazy? You know where
Yes.
you can get cool testosterone support from smart physicians who know what they're doing? You're going to laugh and don't laugh, but this is a true, a transgender clinic. And the reason I say that, I know that sounds nuts, is that those doctors have been prescribing testosterone for 30 years.
True.
They know it like the back of their hand. Now they know how
Right.
to give massive doses. So they're actually going to be smarter about giving a tiny dose than other doctors who
Mm-hmm.
are like, I've never really done it, but I'll try it. So that's just if you live, especially in a big city near a university hospital, you could always try that. It's better,
Mm-hmm.
trust me, than going to an OBGYN who says, I don't really do this. I'm sorry. And remember, most OBGYNs do not have training in this.
Mm.
Crazy, right?
Wow. Okay. Thank you for all that. And then help
There's a
me
lot.
understand
I know.
on the testosterone, is it just because testosterone more just predictably declines? It doesn't fluctuate as much, or why the blood labs on testosterone
No, the labs on
only?
the fact that we don't have FDA testosterone, I think that's the story.
Okay.
me, maybe, is that there was a doping scandal in the 90s with Olympic athletes and testosterone use. So the FDA made testosterone a sort of dangerous medication. And
Mm,
that means because they classified it as so dangerous,
mm,
it's been very hard and very expensive for a drug company to get it passed. So
mm.
we got close. A drug company spent over $900 million to get testosterone across the finish line for women, and it failed by one vote. So it's
Okay.
very hard. So that's why people like me have to do the compounding stuff and use blood work. But that's going to change.
Gotcha.
I do think that's going to change, really. So
Okay.
most people, they start with estrogen. Okay. If you're perimenopausal and you come to me and say, I am losing my mind, my periods are all over the map, I hate my kids, I don't know what's wrong with me. I can draw your blood, but it's not that valuable because remember, it's all over the map.
Mm-hmm.
So if
Mm-hmm.
I said, Tara, I'm going to draw your blood every day for a month, and who would want
Mm-hmm.
that anyway? I'm still not going to have any numbers that tell me what to do. So what
Mm,
do I do? I give you something very simple and low and predictable, like a birth control pill. I know that sounds crazy, but that's what a birth control pill is. It's a boring, even little dose of estrogen all month. And for most women in their 40s, that's all they need. And the symptoms get better and the periods become tiny, cute little once a month periods. And we do that until the symptoms go away, the periods stop, they're in their early 50s. We take them off of that pill and we sometimes put them then on menopausal hormone therapy, which is estrogen by itself as a patch or a gel. And then if you have a uterus, you have to also have progesterone. This is important. The estrogen is what helps the symptoms. Progesterone protects the uterus. You cannot give a uterus just estrogen. It will just grow tissue and could be abnormal tissue. So before menopause, all birth control pills that have estrogen also have progesterone built in. So one pill fits all. You don't have to worry about it. After menopause, if I give you estrogen, I also have to give you a progesterone pill or an IUD with progesterone. So this is like 2 hours of HRT lessons. I'm trying to cram them in,
mm.
you know, but I hope people understand that that's how we do it. And sometimes in perimenopause, we actually don't do the birth control pill. We do the hormone, the menopausal estrogen and progesterone. It depends on what works for you.
Mm.
But anything to calm that chaos. Perimenopause is the hardest thing. We've got to calm the chaos.
Hmm. Yeah, I know. I'm really grateful for all the information and also a little scared. I'm like,
Yeah,
oh my
absolutely.
gosh.
Talk. We can talk for a long time. You can have me back, or you and I can talk privately. You'll be a total expert, I promise. Like my patients, we spend 90 minutes talking this through. So I go on a lot of podcasts, but it's very hard to do a 90-minute
Hmm.
education in this. But bottom
Hmm.
line is do not be suckered into going to some quote hormone clinic from someone who didn't even go to any kind of training and they're giving you IV fluids of with colors and vitamins. I mean, that can feel really good and you will feel better, but that's not hormone balancing. We're not really balancing anything. We're really in perimenopause, just softening some of those fluctuations. Okay. We're just
Hmm.
softening them to
Hmm.
symptoms. That's all we're really doing. And then in menopause, we're again we're not replacing, we're giving a little estrogen and progesterone for really two reasons. Either symptom control, I have hot flashes, I'm grouchy, I cry all the time, or long-term health. I want to stave off dementia.
Right.
I want to lower my risk of colon cancer. Did you know that being on menopausal HT reduces colon cancer risk by 40%? Like nobody even
Wow.
talks about that one. That's
Wow.
crazy. That's a lot.
Yeah, a
So
lot.
women who take menopausal hormone therapy between 50 and 60, so right when menopause starts, they have delayed dementia, so reduced likelihood of dementia and Alzheimer's, lower risk of most cancers, less heart disease, including stroke, and overall greater longevity. So the benefits are stunning. I mean, they're not even like
Hmm.
subtle, they're stunning.
Hmm.
The risks are much different than we used to think. Remember, there was that scary study, it came out in 2002, it terrified everyone. We've now re-examined that study, found the flaws in that study. Unfortunately, that study was super flawed. So the estrogen causes cancer message was incorrect because it was not interpreted correctly.
Mm-hmm.
But it was on every talk show, every newspaper in the world,
Mm-hmm.
and it's been very hard to change the narrative on that.
Mm-hmm. Yeah, I saw Dr. Mary Claire sharing a graph of like after the Women's Health Initiative, it's
Yeah.
just plummeted
Mhm.
in HRT use, and really
Right.
sad because also she was sharing how the suicide rate for women in that menopausal, perimenopausal age group like skyrocketed after that also.
That's
And
right. That's
that's
right.
something I'd really
Yeah.
like to ask you about.
Yeah.
It's kind of multifaceted, my question. I often marvel at, women have been going through menopause forever,
Forever.
right? And haven't had HRT forever.
And
I
haven't been living very long until the last century or so, just so you know, right?
uh-huh.
The women haven't lived beyond menopause in the history of the human race until just the last couple hundred years. So we've only recently even been able to live without ovaries. And it's really mostly because we have modern medicine that can do cardiac catheterizations, and we have antibiotics, and we have
Mhm.
anti-cancer drugs,
Mhm.
right? So
Yeah. And
started her.
so, yeah, so my question is like, there's still many women, most of my clients are perimenopausal or postmenopausal, right? And many of them are on HRT. And then some of them come to me and they're like, no, I'm good. I feel fine. Like I'm postmenopause. I'm sure you've come across, or I'm curious, I would assume you've come across women that maybe didn't come to get HRT because they were experiencing horrific symptoms. Maybe they just learned about the benefits, the dementia prevention and all these colon cancer prevention, all this. What I'm curious in your experience, what do those women experience or tell you when they were like, "Oh, I'm fine. I just kind of think it'd be good for prevention." Like, what's that experience like for women?
It's great because it's really easy. These are women who just want to be proactive about their health. They want
Mm-hmm.
to optimize health span. That means that they know they
Mm-hmm.
want to live as long as they can, but they want to live healthy. They want to be healthy as long as they can. They don't want to be in an assisted living facility with
Mm-hmm.
osteoporosis and a broken hip.
Mm-hmm.
And so they realize, or they've learned from people like Dr. Mary Claire, that the bone is very responsive to estrogen, and that using estrogen, especially in that beautiful window of 50 to 60, 50 to 65, makes you healthier later, right? It's putting
Mm-hmm.
bone strength in the savings account. They experience, look, if they feel fine and they have no symptoms, they don't feel that different because it's all
Okay.
silent. But they often will see that their bones get stronger when they do DEXA
Mm-hmm.
scans for osteoporosis. They they may not know it yet, but what I see, because I've been doing this for 30 years, is they're the ones that are not in an emergency room with a urinary tract infection. They're not in assisted living because they broke their hip.
Mm-hmm.
They're not in the dementia program, know. So it's more that what they're not as they age. And that's
Yeah.
hard. It's a hard
Right.
bind when you're a healthy 3-year-old to go, I'm going to do this. And I'm a little afraid of it because I really want to be healthier at 85. There is a leap of faith there. If you have, or even if you're 55 and you have no symptoms with menopause, it's a leap of faith. It's a leap of, you have to say, I've got to buy into this data that shows all these benefits with very tiny risk, which if
Mm-hmm.
you were putting it on a scale, the scale's way tipped. But
Mm-hmm.
it's also very hard to get past negative info, even if it's been proven to be not true. If I told you that peanut butter caused cancer, and I just put those two words together day in
Mm-hmm.
and day out for 20 years, I don't care how much you like peanut butter, it's very hard to put that on the bread, right?
Totally.
So
Totally.
it's really not that different. It's really not.
Mm-hmm. Well, I'd say the image you just drew for us of what did you say, like a desert turning into like a lush oasis on the vaginal health. I mean, I hope for all women that that is a major driver to at least start out with
Well,
vaginal
look,
estrogen
everyone
because
doesn't
that.
have to get it. Everyone doesn't have to run out today at 35 and get it. There's about a 5-year lag, Tara. So if you go through menopause at 51, which is the
Mhm.
average age, the most common year for women to come to me in tears about dry vagina is 57 to 58. See the lag? But you're very smart, because if you were to start at 51, you are probably not gonna see ever need to come see me and have
Mhm.
that problem. If
Mm.
you start at 45, probably the same thing. Just note that if you start at 43 or 45, you're so healthy now, you may not see the change.
Mhm.
Desert people, the desert crowd will see, you know?
Yeah. Yeah,
I
and
mean,
maybe that improvement might make some women who have been hearing the peanut butter cancer association
you
forever,
also
make them a little
yeah,
more open-minded about like, let me look
yeah.
into this a little more.
And you have to split vaginal estrogen from systemic. I know it's the same word, but you must keep them separate, because vaginal estrogen is only working there. Bad news, not helping everything else. Good news, crazy, insane, safe. Even if, do you realize that even if you're a breast cancer patient, almost all breast cancer patients can actually take vaginal estrogen? I mean, always consult with your oncologist, right? If
Mhm.
you're listening and you're a breast cancer survivor, why do I bring up breast cancer survivors? Because there are over 4 million in the US, not a small group. And if your breast cancer is not sensitive to estrogen, then of course you can take it. If your breast cancer is sensitive to estrogen, you still can take vaginal estrogen because it's not going anywhere.
Mhm.
That's really important, because almost every
Mhm.
breast cancer patient that walks in my door says, now, before you start, I got to tell you, I have breast cancer, so I know I can't take estrogen. And that's when I get to tell them, okay, maybe you can't take systemic estrogen, but you can save the bladder and vagina and use this. And
Mhm.
most oncologists now have learned that that's okay. So you got to keep them separate in terms of risk and whether you're a candidate. There's almost no female on the planet that isn't a candidate for vaginal estrogen.
Cool.
Systemic,
Yeah.
not everybody's a candidate. You can't have an active breast, or you can't have a cancer that's sensitive to estrogen and be on systemic estrogen. Uh,
Mhm. Yeah,
so
it kinda reminds me of like an IUD versus a birth control pill. It's
exactly, they have
localized.
bingo.
Yeah.
That's a beautiful analogy. I'm gonna steal that.
Yay. All right, man. I'm like, what are they gonna kill me if I don't ask you right now? What are some of the other big hitters that come up on this topic for you in HRT that you're seeing women are confused about or need more support with?
I think, I'll tell you in a minute, but yeah, this is like libido. Like, a lot of patients come in and
Mhm.
like, I've lost my libido. I just don't care. I'd be fine if I just watched, Stephen Colbert at night. Like, I'm just fine. And I feel bad about that. And I think the answer is that you shouldn't use HRT to like correct your libido, because libido is very complex. It's how you feel about yourself, how well you know your body, what's your relationship like, how tired are you? Do you have a
Mhm.
mother-in-law in the next room? Do you have a little kid in the next room? A lot
Right.
libido is not easy to just quickly fix, but we do know that libido is affected by estrogen and by testosterone. And so you may want to try um, HT, like estrogen, and or testosterone systemically. You can rub that cream on your thigh and a little will go to your brain. And sometimes that just gently nudges the libido in the right place. That's a slightly different topic. And it's a
Mhm.
long, like we could do a whole hour on that, Tara, but
Mhm.
because it's so complex. There's social
Mhm.
factors, culture factors.
Totally.
But biologically, we know that the brain and the libido part of the brain is hormonally responsive and sensitive, because how it works is those hormones affect neurotransmitters like dopamine. And dopamine is what feels so great when we get, I don't know, a new pair of boots that we just bought online, or we get an
Mhm.
A on our calculus test, or whatever. A hot guy
Mhm.
at a bar looks at us, like that's all dopamine hits, or likes on
Mhm.
on Instagram, whatever. And so hormones actually can positively affect that dopamine pathway. So not crazy to think that they could help with
Mhm.
libido. The birth control pill is an exception to that, because the birth control pill can suppress testosterone and actually reduce libido, which is a bummer, but
Mhm. Okay.
not for everybody, just for some people.
And speaking of mental health, like I mentioned, like I was very upset to see this increase in suicide rate in women. Like, and it just makes me so heartbroken. It's like, wow, like no one was able to help them figure that out. You know, it's a systemic issue, the lack of education on doctors' part. It's not really their personal fault. It's just the whole system is not supportive of women understanding what they're experiencing. So, can you hit a little more on
Yeah.
helping women understand the mental health connection to their hormones during menopause and what they should watch out for and how HRT can help?
Yeah, 100%. So I think I've mentioned that your ovarian steroid hormones, that's the formal medical name for estrogen, progesterone, testosterone. First of all, hormone is not a dirty word and steroid is not a dirty word. And both of those have gotten to be like dirty words. And so it's kind of crazy. Like maybe let's
Yeah.
just call them estrogen, progesterone, testosterone. They work in the brain. They're chemical messengers and they travel from the ovary up to the brain. And the brain is very sensitive to changes in them. So in perimenopause, it's like we're making them go crazy, up and down, up and down. Of course, the poor little brain is like, what is going on? And then not only dopamine, but serotonin, norepinephrine, all these other chemical messengers get affected. So we are literally torturing our poor brain with all this hormonal up and down. That's the connection. Unfortunately, there's an enormous gender gap in healthcare research. So very little money has been spent researching, studying, and recommending things for women to keep their mental health calm through this. Very, very lacking. If I told you the data, you'd cry. You'd say, how could the NIH only spend 2 or 3% of its whole budget on 50% of the population? Like it would just, you'd be livid. But that's actually what's happened. So when a 45-year-old woman comes in and says, and is crying and is saying, I'm thinking of jumping off a bridge every time I drive over the bridge, they mostly get dismissed. The doctor says, hey, you got 3 kids, lady. That's a lot. I get it. Maybe get a nanny. Wrong answer. Wrong answer. Or why don't you try wine with dinner? Wrong answer. That clinician has just dismissed you. You should fire that clinician and go find another. That's not being kind. That's being ignorant. And they're passing their ignorance onto you. What you need to do if you're listening to this is own your own healthcare a little bit. Understand that hormonal fluctuations have behavioral health consequences for many women. And if you have that, depression, anxiety, teariness, short temper, yes, we live in a busy society. Yes, you have 100 emails a day, 3 kids, and a thriving business, and that is a lot for any human being. And yes, you need to learn mindfulness. You need to learn time for yourself, self-care. Again, a whole other episode you've probably already covered. But you also have to acknowledge that, especially if you're between 35 and 50, there's a perimenopausal thing happening,
Mhm.
contributor, and you must find a clinician who can acknowledge it. And
Mhm.
even if they say, gee, I just don't know this field, that's okay. At least they heard you and you can find one. So it's
Mhm.
huge, the connection. It's huge, and we owe it to ourselves. Do you know the highest suicide rate for women by age group is 45 to 55? And that's frightening, right?
Yeah.
So the fact that
Right
this
there in menopause, right? Perimenopause to a T.
Right, exactly. So the fact that the medical community, has never linked perimenopause and suicide, this is a huge blind spot. This is tragic. So
Mhm.
it's not going to get changed next week or this month or this year. Medicine is very slow to change. All our learning is still based on studies done on white men. No offense to white men. That's just how they all were studied. Nothing wrong with being a white man. But you and I are suffering from the fact that no one's linked these dots for us. So I'm
Mhm.
begging your listeners to own
Mhm.
it yourself. Say, okay, I got to start watching influencers or physicians. Dr. Mary Claire Haver's amazing. Um, she's become really a
Mhm.
great resource. I love working with her and speaking with her. I love that she speaks. I mean, if I had a gazillion followers, I'd be happy about that too. So please follow me on Instagram so I can have, but I think we have to find good, reputable sources. Let's Talk Menopause is a nonprofit. Let's Talk Menopause. I get involved with them and they're doing a lot on perimenopause. So please listen to those webinars. Find
Cool.
good resources so you can understand. So if you're having depression, anxiety, or just feeling overwhelmed, it's
Mhm.
not okay to just have someone pat you on the shoulder or put you on an antidepressant. That's it's not actually enough.
Mhm. Mhm. Yeah. Wow. Thank you for that. And yeah, guys, go follow Dr. Sophocles on Instagram. It's Maria Sophocles MD. And Sophocles, it's PH, kind of think like Socrates, but
Yeah,
PH
SOP.
Sophocles.
Yes, very good. Are
Very
you Greek?
Greek.
I'm just kidding.
No. Oh, wow. Thank you so much for this. I want to direct people also to your website. I was reading in the info that I got about you that you have a virtual clinic. Is that correct? And that you're serving over
I do.
30,000 women virtually, US and globally?
Well, the 30,000 women is my practice in Princeton, New Jersey. That's brick and mortar, but the
Wow.
virtual clinic serves
Got it.
people in other countries and in many states because I'm licensed in many states.
Cool. Wow.
Yeah. So that's the clinic. So it is, you can go to mariasophoclesmd.com and then find me as if you need to be or want to be a patient, I'd be more than happy to
Very
help you
cool.
or guide you to someone in your state. Sometimes I
Nice.
do that because it's just easier and people need to get in. But if I can be a resource or a help, I would love that. Would love that.
Amazing. Amazing. So yeah, check that out. MariaSophoclesMD.com. And that's your Instagram handle also. And you've got a book. We tell them the
Yeah.
name of your book.
Sure. Name of the book is The Bedroom Gap. This is a concept and a term that I coined, and Oprah says it's real, so it must be real. And it's the difference in sexual expectations and abilities between partners, women and women, or men and women, that and what that results in, the sort of shame and problems in the bedroom that happen because women don't know how their bodies change and their partners don't understand what's going on. And then
Mhm.
what do women expect they're supposed to be and what should they be? How can we bring our authentic selves to the bedroom? So we learn how to optimize our bodies for sex, but we
Mhm.
also learn to give ourselves grace and make sex fun. I mean, sex should be fun. It's play. It's not
Yeah.
torture. We shouldn't hold
Yeah.
ourselves to kind of crazy standards and especially not standards based on porn because porn is so ubiquitous and when
Right.
people see porn, they think, oh, I guess I'm supposed to have an orgasm in 3 seconds, standing up with all my clothes on. Like, not true. Okay. So
Yeah.
don't, so get, so the bedroom gap is really sex ed. It's for adults. It's what's sex like today? What's internet dating like? What's your body? What's happening to your body? And how can you navigate this? So I
Amazing.
hope you,
Amazing. And
thank
that's
you.
what your TED Talk is about too. So
Yep.
we'll link up the TED Talk, we'll link up the book, we'll link up your website and your Instagram. So guys, definitely if you haven't already as you were listening to this, check all of those out. And Dr. Sophocles, thank you. You're doing big work, very important work. It's
Well,
seen,
I need
it's
you, Tara.
appreciated.
I need you to promote, promote it and help your listeners.
Yeah.
You have such a beautiful following, and I just love what you're doing. I mean, I'm so in awe of all you're doing. So thank you
Thank
so
you.
much. So
Yeah,
much.
and thank you guys for listening. I know I got some loyal Inside Out Health podcast listeners out there. As people tell me sometimes, I'm like, oh, dude, you listen to every single one? That's cool. Thanks. So I see you guys, I appreciate you guys, and we'll go ahead and wrap it up here. Thank
Thank
you.
you. Thank you.
Thank you so much for joining me on this episode of the Inside Out Health Podcast. I hope it's been helpful to you in your journey. If you think that it might be helpful to someone you know, please share it with them. Please share on social media. It really helps me grow the show and reach more people with these amazing messages. And if you could be so kind as to rate the show and possibly even leave me a review, that really helps. So much thanks in advance if you do that. And yeah, please subscribe if you want to hear more of this type of content. I have lots of amazing expert guests on the way. All right. Thank you.